मैं कहीं और जाऊँ क्या? नहीं, आई लव यू। कोई दिक्कत तो नहीं? नहीं।
So, good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's podcast. And today we are starting a brand new podcast series, Pandora's Box Endoscopy, Task Series 3.0, and the topic is Enigmatic Endometriosis. So it's my privilege to introduce the coordinator of this webinar, Dr. Zubin Sir. Sir is the consultant at Aviva Clinic for Women and also Holy Family Hospital, Mumbai, and also Mox Youth Council from 2020 to 2024. I welcome you, sir, and I hand over the session to you.
Thank you so much. Good evening to everyone. And let's not waste any time and let's get started with this interesting session. Could I please have the CVs of the moderators? Yeah. Our first moderator is someone very dear to me, someone I have worked under and admired, Dr. Niranjan Chauhan, Professor and Unit Chief at Sion Hospital, President of MOGS 2022-2023, Treasurer of Foxy 2025 and 2027, and he's just been the organizing secretary of the amazing AICOJ we had this month in Mumbai. Good evening, sir, and welcome.
Good evening, Zubin. We are all rocking.
Yes, sir.
Yes.
Yes. And our other moderator is Dr. Komal Chauhan, Medical Director, Chauhan Maternity and Nursing Home, Senior Consultant and DNB Teacher at VN Desai Hospital, Mumbai, Vice President, Foxy 2025. Good evening, ma'am.
Yeah, good evening. Good evening, Zubin. So nice to meet and connect with all of you on this platform.
Yes, ma'am.
Great. So, thank you, Zubin. It was wonderful to have you. After the nostalgic memories of AICOG Mumbai,
Yes.
we are back to work and we are still reeling through those nostalgic memories. I still remember the beautiful AICOG which we did in Kolkata by Dr. Bhaskar and his team, then Hyderabad, and then AICOG Mumbai. I think all of us have enjoyed, and the memories will still be lingering for a long time to come. Well, without much ado, we would go ahead and I would now call upon the experts who are there. They are the icons of India. They have been there for decades. And we have with us Dr. Alka Kriplani, our professor and HOD from AIMS Medical, New Delhi, and now presently at Paras Hospital. She is a Padma Shri awardee and she has been the president of many organizations, namely AOGD. There is Delhi Medical Association, and we have the Gynecological Endocrine Society. And
बस निरंजन, okay.
Yes.
Thank you.
Thank you, madam. And welcome, madam, for this wonderful podcast. Well, Dr. Prashant Mangeshikar, sir, is an icon. He is the president of APAG, our Asia Pacific Gynae Endoscopy Association. He has been also the president of IAG, and a great person, a very good surgeon, amazing versatility. I had the opportunity to be his house surgeon and registrar in Rajawadi. Sir is going to join soon. He has been doing endometriosis surgery since morning, and I'm sure he will be there very soon. Great. And I have my friend, Dr. Bhaskar Pal, the president-elect of Foxy, the man on the mission. He is
That's enough.
A very good avid
That's
leader.
enough, Niranjan. I think the only introduction
Yes.
is we are very old friends since.
Yes. So Bhaskar, you have got a lot of hats, and we are looking forward for you to be the president next year and take the Foxy further ahead. Thank you so
Thank
much
you.
for joining. And last is Manjula Anagani, another Padma Shri awardee. She is also the head of the IAG chapter in Telangana. She has been a Guinness record holder of maximum number of fibroids removed from a single patient. She practices in Hyderabad, and she has got many students and fellows who have come and visited her and seen her surgery. An amazing personality. Thank you all of you joining. So today we are going to have a wonderful podcast. Podcast is the in thing, and we are going to dwell into them. Madam, I would start with Dr. Alka Kriplani first. Madam, would you please highlight?
Before you start, Niranjan, I cannot open my mouth before I really praise you people and Mumbai AICOG. And you and Komal were, shining away. Huh? So it was great job done.
Yes. And
Thank you.
I just want to add one thing. So we remember the Kolkata AICOG with Dr. Bhaskar Pal has done. Then the Mumbai one, and we are coming to Delhi, Madam Alka Madam, next year.
No, Bhaskar, the job Bhaskar did, मैं तो उसकी वो हो गई, क्या कहते हैं, फैन हो गई भास्कर की. ऐसा फ्लॉलेस था भास्कर का काम कोलकाता में.
Absolutely great. So, Madam, I'll start with you. I'll take few questions and then I'll move on to welcome Dr. Anagani. Thank you for joining. I just
Hi Manjula, what a pleasure.
How are you,
All
madam?
my favorites.
How are you, Dr. Bhaskar?
Welcome. I think everybody is joined, and it is the right moment to have a short prayer. Saigiti, can you just have that prayer with a lamp lightning, because it is our first episode, so
Yes,
we don't want to miss it.
Let's pray all to Saraswati.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Okay, Madam, thank you. With that, Vandana and Saraswati Stotra, we go ahead with now with Madam Alka Kriplani. Madam, would you please highlight us something about endometriosis? How is the disease? What is the percentage, and how would you, see them in your 40 years of practice? Please guide us.
Yes. Endometriosis is presence of, endometrium outside the lining of the uterus. And nowadays we see a lot of, outside diaphragm, lungs. It must have been there. Now diagnostic modalities are better. The question you asked is very nice. In 40 years, when I was a resident, the majority of cases in Lady Harding used to come in private ward. So we used to think it is disease of rich. But now what has happened, Niranjan, it has become so common. I used to take exams to Kerala, and I used to see so much of endometriosis in young girls. So it's no longer said the disease of rich. I think it is late childbearing and better diagnostic yield because of presence of ultrasound and other diagnostic modalities, more sensitization. So diagnosis is picked up also. Although I know that there are number of studies showing it takes 5 to 7 years after the symptoms that the endometriosis is picked up. So what I was starting with, when I was a resident, it was very rare. Maybe we were in government system, and in those times, half of our OPD was patients requesting for MTP. Now majority of patients come, they are not able to have babies because late childbearing, we are exposed to so much of pollution and toxins. I think these are the reasons endometriosis is getting more and more common also. So in 40 years, and then I started doing endometriosis. So we are very skewed. If you see in my practice, so endometriosis is very common. But as such, it is becoming very common, and we should have high index of suspicion when a patient comes with dysmenorrhea, infertility, because diagnosis is also, not delayed. So endometriosis is a very common problem. Yes.
Yes, Bhaskar, I'm coming to you. What is your experience with endometriosis in your side of the practice? You have been also in UK. If you compare with UK and Indian population scenario, what you used to see in 90s and now what are you seeing now? Can you please elaborate on those aspects?
Thank you, Niranjan. Thank you very much for inviting me. I think Madam started with the anecdote that when she was a resident, she used to think that it is a disease of the rich. Niranjan, we trained with Dr. Patkar, and he had this theory because in Sion, the most endometriosis we used to see among Bengali and Keralite women. So his theory was that it is more common among fish eaters. And we also see a lot in Guwahati, for example, in the northeast. But I think, as Madam said, there is two reasons that we see much more endometriosis. Number one is that people are delaying their childbearing, and that is why endometriosis is becoming more common. And secondly, when we were residents, the only endometriosis we diagnosed were the red powder burn lesions. Now we know that it comes in all shapes, it comes in all colors, all sizes. So our understanding of endometriosis has got better. And that is, I think, has been the sea change. But what hasn't changed is that it still remains a very frustrating disease to treat. And I would, in spite of being an endoscopic surgeon, I would say that there are two parts of the surgery. One part of the surgery is being technically good, which I think the younger you are in India as an endoscopic surgeon, you're technically more gifted. But the second bit that comes is with wisdom. I think there are too many, I think tailoring the treatment to what the patient is coming with is a big issue. Now we know that approximately in our practice, incidence of endometriosis is between 6 to 10%. In infertility practice, the incidence of endometriosis is around 35%. The issue is, what is the patient coming to us with? The patient is coming to us with either a pain, number two, infertility, number three, a cyst, or number four, a combination of any of these three. So our treatment should be tailored towards whether the patient is wanting to achieve a painless life or rather a controlled pain, or whether her primary aim is to go for fertility, and accordingly we need to tailor the management. That's, I think, one issue. That is where the issue of wisdom comes in. And the second issue is that although we say that laparoscopy is the gold standard in diagnosing endometriosis, I hope 3 years later we wouldn't have to say the same thing. With ultrasound, you can diagnose it very reliably, but only in those who are trained to pick up endometriosis. The International Deep Endometriosis Group has come out with their ways of looking for endometriosis, which starts with an examination and then doing an ultrasound. But then there are very few people who are trained to do that. But I think a time will come when we would be able to reliably diagnose endometriosis on ultrasound, and we do not have to subject everybody for laparoscopy. So as I keep saying, one more thing is, I keep telling my patients that endometriosis is a very frustrating disease, and it is like diabetes or hypertension. A disease where we do not know the cause, we cannot cure it. We can only control it. But the advantage, I also at the same breath, I tell them that there is so much of money going into endometriosis research that every 3 to 5 years we come up with a new medication. And I think at the present moment, of the aim of endometriosis surgery should be that delay the first laparoscopy as long as possible and minimize the number of surgeries a patient have in their lifetime. That's all.
I'm sure, Bhaskar, there is going to be some amount of unruffling of feathers when Dr. Prashant Mangeshikar sir is there. Welcome, sir. I have already introduced you, the icon of India, the endoscopist, the great man, which we all went through Rajawadi in 1990s, and now the current president of Apache. Sir, welcome, sir. I know this is the time when you are going back in your catamaran from your consulting after finishing the operations to Alibag. And I'm sure you will have a great feast tonight also of fish. But I know I have captured and catapulted you in this amazing video podcast. And what can I ask for all the big Padma Shris and the big icons here? Sir, we just started with a discussion of endometriosis and how it affects the patients of Indian scenario. And we compared that what was in 90s and now what we are dealing in 2025. And Bhaskar just said that it's more common in fish eaters. I don't know whether you agree with him, but it's quite.
I didn't say that. I quoted Dr. Vivek Patkar saying that.
Yes. Well, Dr. Bhaskar, to be precise, Dr. Patkar, sir, you all know him. We all love fish, and it's more commonly, that's what he said, found in Guwahati or in Bengalis, probably Western. Sir,
And
I
Kerala.
want your opinion, sir. I want your opinion in the last 40 years of your practice. That is the main question which we are asking. Firstly, to start with, I'm going to come to Dr. Manjula, madam, also. What is your scenario, sir? Last 4 decades, things have changed regarding endometriosis.
Prashant, you're muted.
So please unmute yourself.
Yeah.
Okay.
Yeah, thank you. Welcome.
Thank you for your kind introduction. I'm just an ordinary man. I am not one who likes to brag about, but I am there since the last 40 years. I'm a second generation gynecologist. And during the times that my father used to deal with endometriosis, there were almost about 3 or 4 laparotomies that he did in those early days when the treatment was just laparotomy. And my sister, as a matter of fact, was the only case that I ever saw my father do a laparotomy for severe dysmenorrhea. Everything was normal in her, but she had pains. No amount of medication ever worked on her. And he did a cord sympathectomy on her. Now, that's a very strange operation where COTS described. But coming back to 40 years, the incidence of endometriosis in my practice for several years was around 65%. And since my son focuses only on endometriosis and we work together as a team, the incidence of endometriosis is 95% in my OPD. So that's because now people are getting aware of pain, and that pain is not something that's going to disappear once you get married, and it continues. It's not that you're going to get pregnant and the endometriosis is going to disappear. These are all myths of the past and grandmother's stories. And yes, as Vivek did say that it is more common among fish eaters, it's not because we are fish eaters, it's not that the fish causes it, it's because we are Dravidians. And all the Dravidians were pushed down to the south with the invasion of the Aryans. So the Aryans remained in the northern part, but the Dravidians, the Harappans, were pushed along the coast, right from the coast of Bengal down towards Kerala, past Tamil Nadu and Andhra Pradesh, and then swung upwards into Goa and into towards Bombay. So that's the reason why they said, oh, fish eaters have a very high incidence. Yes, we eat fish because we are all Saraswat Brahmins that were pushed down when the Aryans came in from the north. So we carried our brains and our endometriosis together. That's what they say. But today it's not restricted only to the coastal region. The incidence of endometriosis today worldwide is around 1 in 7 women have endometriosis. Is more common than diabetes. Yes, it does require a good dedicated team to be dealing with endometriosis. As you rightly said, that it should be one surgery that should be enough. I do not believe in medication for endometriosis when it's advanced. In very early endometriosis caught at an early age in teenagers, you can control it. But if you can't control it after fair trial, do not continue giving it for months together or years together. We have had patients who have had 30 doses of injectables being given with no relief, and they come in for surgery. They're already osteoporotic. And as Keckstein very nicely said, if you don't know how to operate, it's good that you're giving medication, right? And I'm surprised that even the past president of the IAG once said there's no rule for surgical laparoscopic surgery in endometriosis. And I don't know how the audience gulped it down till I barged in. But well, you've got outstanding surgeons who stand outside the theater. They're gonna make such kind of remarks. Or if you're a social gynecologist, where you're seen more, being coronated for a presidency, okay, as we just had last week, I was told. So then such stories are gonna be there, and the myths will continue, and the pharma industry will continue to grow thanks to these people. So we need to catch them in the bud. We do not require endorsement by some European society. They approached me also, said that you pay us 5,000 euros per visit, and we will make your center a center of excellence. Today, one of the Ambani hospitals declared themselves in the newspaper. We are the only center outside of Europe that is endometriosis driven. How many bowel resections has that center done? Probably about 10 in a year. Right? We do about 4 a week. And we're not bragging. We've got evidence there. You press a button on an intuitive. You can find out how many cases Alka is doing it or Manjula is doing. Everything is there. It's not anymore. You can guess. Tell the people, oh, we're doing so many cases. It's all there. It's out there in the open. Anyway, my thing is, it should be a multidisciplinary team that does the management of endometriosis. We mean the primarily the gynecologist does all the diagnosis, and a good surgery, a good history taking with examination. The gynecologist himself should do himself or herself should do the ultrasound and then read the MRI himself or herself. Right? Don't wait for the radiologist to write, because below that the radiologist write clinical correlation required. Now, you need to come to a diagnosis, tell the patient, okay, this is the extent of your disease, whatever classification you use, an NGN classification, etc. You must tell the patient, look, you've got bowel involvement, and we're going to do a bowel surgery, do a bowel disc or resection, and then work with the team that you must be conversant to do your bowel dissection and the resection yourself. You just call for medical legal purposes, you call the colorectal surgeon, who has to be in the theater as a planned procedure, not brought in as a surprise, because he may not have the time to come at that time. So the patient has to be prepared that, look, I'm going to chop out X centimeters of your bowel. Is there bowel involvement? So a good examination in our center takes a good 45 minutes to examine, do ultrasound, and do the MRI. The patient does not come to our clinic without an MRI, preferably, because if she's coming from out of town or whether she's coming from the limits within Bombay, the MRI must be done. We look at the MRI ourselves on our computer and gauge what is the extent of the disease. So the patient is already counseled before what is going to happen to her and how many days she's going to end up staying in the hospital before she gets admitted. So, and of course, the consent is taken for all these procedures before. So you need to have a good discussion with the patient, explain to the patient, explain what her pathology is, both with ultrasound and the MRI. And preferably that you should learn to do the ultrasound yourself, right? And I'm very kind of scared because the modern generation committees that are there, be it the IAG or whether it is infertility committee or whether it's Foxy, they have come out with this strange thing saying everyone can do laparoscopy, everybody can do IVF, ART. I mean, what are we? There are specialists who are meant to do this. You know, if you generalize and say everyone can do it, I mean, it's going to be a very sad situation because it's going to drive people up the wall. Alka, what have you got to say on this?
I want to say two things about. First, I want to say about Prashant. He will call a spade a spade. Initially, I used to think he's critical, but now I am a big admirer of Prashant because he's the only whistleblower amongst us. We all are goody people, and he speaks his mind and he's fearless. And secondly, I don't know how he knows everything about everybody. I'm so surprised he's not coming in our conferences. He is not gossiping with us. He is not, but he knows everybody and everything about. So these two qualities make him, very different than us and different people. We really admire you so much, Prashant. Whatever you said is correct. Whatever you said is correct. But don't be so critical. There are areas in our country, Prashant, where you don't have very, expert people like you.
No.
But you have to be reasonably good. And secondly, endometriosis is one thing. You can't be just a cutter. You can't be just a physician. You really have to be a combination of both.
Correct. Exactly. I mean, and it's a multidisciplinary team. You need to have a urologist. You need to have a colorectal
Those people who say that we don't take any colorectal and all. I have seen so many patients with dumping syndrome, sitting in the washroom. So we have to, I'm very happy Prashant has brought out this point. It is not that we cannot be cutters, we cannot implant ureter, we cannot run staplers. It is how exactly you are trained, and everybody should be doing best of it.
Correct. I mean, it's and then we require a psychologist. We require. I mean, there's so many things that they need the patient. I mean, it's not that the patient imagining that she's got pain. The pain is there, but then it also plays on her mind, and we need to have a physician, a GI surgeon. You require a psychiatrist or a psychologist to.
One more thing, when people put them on medical therapy for very long, please be aware it takes away silently. Kidney goes away. We see patients. It infiltrates. So we can't say just don't do any surgery. You have to see for vital organs. That is also very important message I want to give.
Yes, Manjula, I want your opinion about what sir said, and then we will go back again to Dr. Bhaskar.
Thank you, Dr. Niranjan, for having me here first thing. And I've had the luxury of listening to the legends before I can make my opinion heard. So it makes it much more easier for me to just continuation. So I strongly believe that in all the theories what you have come, there is genetics and epigenetics. So genetics, yes, like Dr. Prashant said, yes, we are Dravidians, we have the thing. But the epigenetics has a huge role now. That is pollution and the endocrine disrupting chemicals which are coming. So it is basically the sanitary napkins which have plastics in it, which are closer to the genital organs, which have the gross increase of the endometriosis. That is the first point. Second thing, when I want to say it in a different way, that हमारे घर के सामने कुछ कचरा है, उसके ऊपर कितना भी परफ्यूम डालो, कचरा का ही smell आएगा. So unless we remove the kachra and put 2-3 drops of scent also, perfume also, you get perfume smell. So depending on the disease and the effect it has, and unless we remove surgically, then give medical management, it does not work. So my saying to the patients would be not as simple as Dr. Bhaskar said, diabetes or hypertension. I tell them it is like cancer, but not cancer. So there is no question of cure. We have to do a surgical management if necessary, depending on pain as the main factor, then followed by medical management, which is like chemotherapy. So I think I've categorically talked to people, and then patients really agree. And they, like everybody said, we all agree to one factor. It has to be minimal, only one surgery if possible. Good surgery. Patient has to do their homework and come to the best surgeon. If we cannot do it, please send it to the surgeon who is master in that particular surgery, followed by medical management till they think of pregnancy.
Manjula, you have raised a very, very important point. Very important. Yeah, one for etiology, these pets thing. And second, number of surgeries. You see, I am sure you also, we are handling with so many cases of pelvic abscesses because of some kind of intervention done in endometriosis. So these two things are very important. Don't meddle with endometrioma. You needle it, you just do an incomplete job, you drain it, patients land up with pelvic abscess.
Yes, ma'am. Dr. Niranjan? I think the moderator has gone off the thing, so we can discuss among ourselves.
No, actually, there is a URS going on. You can imagine the noise. So that's why I curtailed the audio. There's a lot of noise here. Komal, can you just take over till I join back?
Actually, there is no noise which we are hearing, Dr. Niranjan.
Okay, great.
Yes, I know that we have.
What is URS? What is URS, Niranjan?
Madam, it is a public procession of our religious friends. They have a 10 days URS here, like maybe Manjula madam can understand. So they have.
I have a vague idea. I recollect.
So now with this, we can go back to the surgical aspect now, Bhaskar. Would you prefer to do ablation? Would you use to do the drainage only and remove the cyst wall so that further management can be done by a medical line of treatment? Or would you prefer an excision? So there are three aspects I would like you to highlight on the surgical modality, availability, and the latest scenario which is there.
Okay, I think it all depends on what are you operating for. Okay, I think Prashant always is, somebody called me mercurial, but Prashant is much more mercurial than I am. And so that is why Prashant's statements are always trying to spark up controversy. But I think before I get into the surgical management, I don't think any organization says that everybody can do endoscopy or everybody can do ART. No organization does. But at the same time, whenever an organization puts out a guideline and says, suppose it says that endometriosis can only be operated by people trained in endometriosis, which is absolutely right. There would be places in India where somebody has to do it because there is no endometriosis, well-trained endometriosis surgeon available. And they might be hauled up in court by saying, why are you doing that? So I think as an organization, you have to remember that as well. Now, I think...
Bhaskar, if I may just intervene, I don't talk off my hat. I talk with facts.
No, I know that. I agree.
So when I'm quoting, I'm talking about the Eagle project. Each and every gynecologist can do laparoscopy or something. I don't know what the
No. It is can learn.
Excuse me, can I come in? You two mercurial people, please leave it for private conversation.
That's okay.
Audience is there, so let us proceed. Thank you.
I think that is learn. I think whenever we talk about endometriosis surgery, there are some things we need to understand. Number one, that the first surgery should be the best. So it should be the attempt should be that it should be operated by somebody who's trained in diagnosing endometriosis and treating endometriosis. Number one. Number two, if you are treating a deep endometriosis, you need a multidisciplinary setup.
Yeah, that's what
you need a colorectal, because number three is that do not expect that you will do a half-hearted surgery and medicine is going to take care of it. No, it is not. No. Your surgery has to cure it, and medicine is essentially to prevent recurrence. Now, what kind of surgery you would do? As I said, that I wouldn't be as ambitious as Manjula to say that it would be great that if we could restrict somebody to one surgery in a lifetime. But I think we should try and at least restrict to 2 surgeries in their lifetime. One is a conservative complete clearance of endometriosis, and then managing them with medicines, and later on in life, at some stage, if required, do a radical surgery where you remove everything. Now, when you are doing a conservative surgery, it depends on whether, and you've got a cyst, whether you're going to do a cystectomy or whether you're going to do an ablation. It would depend on 2 reasons. Number one, what is her fertility status. If it is the main complaint is the pain, fertility is not an issue, she's got a good ovarian reserve, you should always do a cystectomy. The only time when we will do a drainage or an ablation is when somebody is got already compromised ovarian reserve and you are doing the surgery because the IVF specialist cannot get access to the ovary. That is the only time I would do a drainage with ablation. I think there are some early reports coming in about sclerotherapy, but we would leave that in research setting till we have more data about sclerotherapy.
Bhaskar, sclerotherapy is already, there are so many abscesses coming in. So sclerotherapy, take it with
Madam, I'm talking of laparoscopic sclerotherapy, not ultrasound-based sclerotherapy.
Even then, there are so many adverse reports.
As I said,
people are listening to us, so I'm very skeptical about.
That's why I said that we should not talk about it in clinical practice. It should be only in research settings at the
because Dr. Bhaskar, you might need 7 to 8 times to prevent the recurrence. Recurrence rates is very, very high.
No, we don't do sclerotherapy. I'm just saying that is something about which reports are coming in. Some people are giving the problem when you are looking at reports are that the results are going to be different when somebody who's an expert in that is doing it and somebody who's just saw that on a video and attempting to do it. That is the problem.
Yeah, what sclerotherapeutic agent you are putting, how you are putting, even then there are many problems with it anyway.
People use methotrexate also.
Yeah.
It can have its own thing.
I think at the present moment our discussion is only on cystectomy or drainage with ablation. And I think I tried to say...
So majority of time cystectomy, but be careful that cyst should be only cyst lining. Wherever you put pitres in it, that becomes the layer. So the most superficial lining needs to be removed.
Absolutely.
Yes, I agree.
I need to take leave because I've got guests who have come. But just to, when you're talking about sclerotherapy, please look at the article. It's a leading article by Horace Roman from Bordeaux, where he talks specifically about sclerotherapy which was described by a French surgeon, and he does regularly sclerotherapy. They use a 97% absolute alcohol, and it is done in such a way with a Foley's catheter inside silicone to see that there are no spillage that occurs. You do a rinsing and you wait patiently for about 15 minutes while the alcohol works in. And I've seen his results intra and post-op second scopies that were done where it has. The only reason why I have been skeptical to use the alcohol in my practice is because we're trying to see how we can get that alcohol ampules here. They're very expensive. And the neurosurgeons told me you can use a bottle of alcohol, which is 1 liter, and it's sterile, and just put it into, they use it for the brain. I mean, wherever they use it. Okay. For
which bottle, which alcohol?
I'll send it, absolute alcohol.
Which brand of alcohol?
97.
Sir, one point I wanted to ask: how will they put it with the Foley's, sir, in laparoscopy?
You inject it. I can share the video with you. Yeah, I'll share the video with
How
you.
is the Foley's put into the system? Just
it will burst, yaar.
No. You put and you drain the cyst out with a suction, and
Yes,
then
sir.
after that you put the Foley's catheter inside, inflate the bulb, lift it up so that no spillage will occur, and then introduce the alcohol.
Like EAE के वैसा. पुराने ज़माने में we used to put extra amniotic.
Yes, correct. Exactly. Like that. So they have been doing this laparoscopically, and there are many centers that have reported laparoscopic sclerotherapy with good results, and we plan to do it. I guess Ramesh was trying to do it, but he did not give me full report on what he's actually done. But if you check with Horace Roman, and you can look on, if you write sclerotherapy by Horace Roman on YouTube, you see the full video.
I have seen his articles also.
Yeah.
Why you are leaving, Prashant? Please wait for half an hour. It's just 25 minutes.
I've got people who have come, and my wife is not here. I'm hosting them for dinner, and she's in Bombay, so I need to run the show. Yeah.
Bye.
Okay. Okay. All the best, Niranjan. We need to see you there. Okay.
Thank you, sir. Thank you so much. It was a great thing. And the recent advances which Bhaskar has shared, and Prashant sir. Sir, I can tell you on YouTube presently 200 people are watching. And of course, there are registrations of 85 numbers, and it's going to grow. And this is going to be the video podcast which we are going live now. And we have still 20 minutes. I will go ahead with the
bye.
Thank you so much.
Manjula, Alka, Bhaskar, and everyone. Niranjan.
Bye.
Thank you, sir.
Next time you come into Bombay, please come
I'm
to
the
Gateway of India and come to Alibag, and I will host you. You can stay at my
Then
house.
you will have to leave a podcast and welcome us.
Absolutely.
I will hold you for that, sir.
Yes, sir. I don't work on weekends, so you come on weekends. Bye. Bye.
Bye.
Dr. Niranjan, Dr. Bhaskar, everybody, what I feel is when the technique has evolved so beautifully with Pitresin subcutaneously, and we are removing only the lining, again, by practice, I think that is giving the fantastic results, because when we do too much of a surgery, we end up losing the reserve. When we do too less a surgery, we end up having recurrence. So you master the art and then you do it. I think the results are great, because we are not just looking at fertility now, we are also looking at recurrence, because that woman is going to be with us for lifelong. But like Dr. Bhaskar said, the reason, are they coming for pain? Are they coming for fertility? This is very important. Second is AMH level before and post is very important. And the reach for the IVF specialist to go and retrieve the oocytes, so that contamination of this fluid does not happen, then the quality of the oocytes also will be there. So we have to look at the pressure of the cyst on the hilum and the quality of oocyte. Plus, genetically also, these are the people whose quality of oocytes will be bad.
Excellent, Manjula. I would like to just add one thing, that we can make her, take ovas and make embryos and then do clearance surgery.
Yes, sir.
In many situations, it is a good option.
I think
when this comes in a way, then surgery should be first. Otherwise, they can do that and then come for surgery.
I think what Madam says, that is what we do when somebody comes with pain and infertility. We say that please go for the ovum pickup, then we'll do a clearance surgery. And then, so that even after that, if you cannot conceive, then at least for IVF, you've got your eggs.
We tell them it is like FD, you have something in your account.
Insurance. And second thing is, like I said, only if this is coming in the way for their oocyte pickup, then surgery can come first.
Yes, I think we will move ahead now. There is a good consensus about doing a laparoscopic surgery, about going ahead with treatment given to the best. Fertility options have to be given. OM pickup to be done before if you go ahead with a clearance. And post laparoscopy, she needs to conceive as early as possible. That's what would be the best option for a
I
patient.
also want to add one sentence here. The reason why when we all spoke about to get the oocytes done and then again do surgery is because if these people conceive with the pregnancy with endometriosis, there'll be high chance of PIH, preterm, and we have placenta previa, all that also. So obstetric outcomes also will be affected because of the thing from the endometriosis.
Niranjan, I want to add one more point. As you
Yes,
said,
ma'am.
laparoscopy should not be done only for diagnostic purpose. Now we
CNT.
have such good imaging. So it is not a must to do laparoscopy in this time 2025 just to diagnose
You
endometriosis.
have to take
Ideally,
operative
ideally we should be able to see and treat it.
Yeah, see and treat
Yes,
and therapeutic.
see and treat, absolutely. And a good management, the first management, the good surgery approach. And of course, if you're dealing with a difficult endometriosis, you need to have a multidisciplinary approach.
Yes.
We also discussed about Horace Roman. He was there in AAGL 2015, then he was back again. His students have also come here. Basma Darwish, he was his fellow for 3 years, and then she has gone now to Bahrain. Probably Manjula, you might be knowing. Now,
Yes.
what is the use of, see, in India, we are using, say, bipolar, then we have NSEAL, or we have Ligashore, or we have harmonics or whatever. But what is the role of lasers? Can someone highlight on that? How best it would be good for fertility point of view? I don't know whether any of you are using lasers.
Can I come in?
Yes,
Yes,
ma'am.
madam.
At Institute, years back, we had CO2 and DAG laser. Then lasers went into disrepute. They were, in all the OTs sitting in the corner. But I know Dr. Hafiz Rahman propagates a lot about using laser. He says ovarian reserve. But by and large, the evidence is using laser. Recurrence rates are higher than doing a good cystectomy.
Equivalent to the ablation, which Dr. Bhaskar said, when we are trying to do only ablation, either laser or a bipolar can be used for ablation.
So many people they have started again with lasers, plasmas, but I think cystectomy, good cystectomy is still the gold standard.
Yeah, because
Okay,
it is the
madam.
depth which is important. When you are putting the depth of the laser through which it has to go, then that is the same as cystectomy, which goes into it.
Yeah, absolutely. It's about 2 to 3 millimeters depth, or maybe 1 millimeter depth, but that is also an option which there's a lot of people who are also proposing to do with only laser surgeries. Maybe not here in India, but there are many centers abroad also who prefer lasers. Maybe there is a difference of opinion, but surely, Manjula, you can highlight on
I
that.
just wanted to add one point that might work for, when we talk about DIE, we talk about more than 4
Yeah.
mm. Also. Then how can a 1 mm thing can work? Only maybe a superficial endometriosis where it is butterfly peritonectomies can be avoided, lasers can be used. But otherwise, when it is DIE, it has to be a good surgery.
I think, Niranjan, rather than the energy source, it is the person who is using it. You
Okay.
see so many surgeons, these general surgeons being wife of his, they use monopolar so beautifully, I tell you. So it is not the kind of energy, it is how you use it.
Wish
Mastering.
I could get Arnold Watis on this program, but I'm sure we will see him in the near future with us sometime. And Bhaskar, we are awaiting that in your presidential year, we will have a good, wonderful experts coming from all over the world and, giving us the whole idea. Now we move on to the rectovaginal plate. How many cases you have seen with rectovaginal endometriosis totally stuck up there? And then you have, I mean, what I'm talking is stage grade 4 endometriosis. Would you go ahead with all the level facilities being there and the center which you have? What is your experience on that, Dr. Manjula?
Definitely, see, the patient main thing is dyspareunia, dysgesia, and the POD is gone. Like good ultrasound will tell us whether it is involved or not. You have to be prepared and then go in. So what I have seen in the recent times is once you dissect the pararectal space, it is much more easy to get the retrograde fashion and then separate the rectovaginal plate separately. And then you have the rectovaginal septum, which can be separated, and the nodule, which can be excised. And now I have seen Dr. Nutan Jain presenting very beautifully with a swab of the indigo carmine or anything inside the POD, and then showing the technique, firefly technique or whatever technique you want to see, and you have the beautifully it comes out with whatever is there. So I think lot of literature and advances are coming. But even if you don't have those techniques on your endoscopy thing, if you start coming from the novice area, then coming into the center and doing a retrograde, the way we separate bladder from the anterior uterine wall if it is adherent, retrogradely by lateral window technique, same way, I've seen much more easier to separate the bowel from the rectum. And then comes, depending on the depth of invasion, whether you're doing shaving, whether you're doing discoid, or whether you're doing end-to-end anastomosis. So this is what, but yes, it has increased a lot. And it is the bowel endometriosis and POD, which has increased a lot in the recent times.
Niranjan also asked Manjula that
Yes,
how often you are. Majority of time we are doing shaving.
Yes, ma'am.
But
Yes,
if the thickness is involved discoid and we call colorectal for these anastomosis, I want to make a comment. I don't want to be mercurial like you people, but I want to make a comment that many times I see people are telling that they are using so many staplers and so many cases and they are resecting bowel 4-6 times in a week. Baba, we are doing so much of endometriosis. Maybe patients in the north are not having that many deep endometriosis requiring staplers and end-to-end anastomosis all the time.
And we should not forget the effect of Dynogest or any good medical management. Elagolix is also coming after that.
Yes, Madam, we talk about that. The new kid on the block.
No, I will. I think
differ.
I completely agree with Madam, but I will put it a little more harshly.
Right.
If somebody comes and tells me that I do 4 to 6 bowel resections in a week for endometriosis, either that is a place where gynecologists are sending endometriosis that they cannot operate, but most often than not, a lot of resections are taking place which could have been managed by shaving or discoid resection.
Yes.
But
I think
Bhaskar, we are getting so much of referral, but we are not
I agree.
needing so much of bowel resection.
Madam, I'm trying to be a little diplomatic. But I think the more senior people you talk to, like
but we should give this message at least.
Yes.
I
To
get
Dr.
patients and my husband, who is a very good surgeon, tells me, you people, she says, I'm sitting all the time in the washroom. He said, because rectal capacity is reduced so much and they have this dumping syndrome and things like that. So we have to be very careful about these very radical procedures. And we should audit how many are required.
That is what I started off. That is why I started off with, Madam. I will tell a small story. I was in Guwahati and I was talking that please don't do ultrasound aspirations because they give rise to abscess and infections.
Right.
Now, one person in the audience got up and said, I've been doing it for 15 years and I have not had a single one.
Baba, he's very lucky,
No,
but we have to teach
Madam, I'm not finished.
Experience
So
versus
after I finished the talk, another gentleman came up and told me that he doesn't get the abscesses because they all come to us.
To others.
Okay.
Doesn't go back to the
I
same.
have spoken to younger surgeons and I said, you all are making the life of a 22-year-old. The solution that you are giving them is worse than the problem that they came with.
True.
And in terms of dumping syndrome, and they say we counsel them.
I am very, very happy, Bhaskar, that
you have taken a very important point, because nowadays on WhatsApp group, I'm sorry to say, I'm not criticizing, left, right, center, you find all those videos just going across.
That's what Niranjan, that is why I said at the start that I am not going to, if I am operating because I can do it, that should not be the approach.
Yes.
I think I'm going to make the patient's life better than what it was. Because if
you have not done a bowel resection, you are not a good surgeon.
Correct.
So,
Madam, what I have to say is they're trying to fit the patient to the surgery they know.
Correct.
Instead of fitting the surgery to the patient.
I think there is a saying, if you have a hammer in your hand, everything in the world looks like a nail.
Right.
I think Bhaskar and Manjula, we should give this message very clearly
And I
and
mean, so
always from
many
all.
years we did not do it. Why do we need? And none of our patients had any problem. So what I feel,
Agreed.
one good scan, one
Shaving in
MRI.
majority of times is such
Don't
a
need.
great thing.
Yes, ma'am.
Absolutely.
So I think, Dr. Niranjan, you got your point. We
I
don't
think,
need to do that. So the
yes,
take-home message
I
is
think you have to be reasonable. You need
yes,
to understand the importance of the age of the patient, how young that woman is, how is her life going to be after this procedure, and is it worth it to undergo all these things just because you are aware of it?
yeah,
And there are various other options. I have seen so many rectovaginal plates
yeah.
operations, and we have done in our times, 90s and 2000s, open surgery. If you are getting a right plane, you will just go
Yes.
in a proper plane. You will just go in and absolutely remove the whole situation
Just
rather
want to
than
add
going
one
in a wrong plane.
sentence.
Yes.
Excellent,
What,
Niranjan,
yeah,
but don't say that your generation. You are totally
much
present
younger
generation.
generation. Yeah. I
Younger,
just want
younger.
to
I'm
add
not.
one thing. One
Yes.
thing I wanted to add. See, what I tell my patient is what my eyes can see, I will remove. What my eyes cannot see will be by medical management after that. So whatever,
Excellent.
that is what is important. What my eye can see is definitely what MRI is showing and the way they glorify it. So usually the shaving, whatever we can feel it, proprioception and all, we remove it. And that's it. After that, medical management.
Excellent, Manjula.
Excellent. I think that is the message you need to understand that endometriosis, and you know how much best ever you do a surgery, you might be the best in the world. I will tell you that patient comes back here. The patient comes back again, not now, maybe after 3 years, 4 years. The only thing that she needs to conceive as early as possible. And I think that will make a lot of difference to the whole situation. And of course, all the discussions which you
To
have.
add fuel to the fire, nowadays we see so much of adenomyosis along with
Yes. Same.
endometriosis.
Yes, yes, absolutely. Maybe out of some 10 patients which come to my OPD, six of them are fibroids. And out of those six fibroids, when you go in, you don't find a plane, and two of them are actually adenomyotics. And absolutely, you are struggling there. So we have to understand that the incidence of internal endometriosis also increase a long time.
Coexistence of fibroid
And
and
it
adenoma.
really requires lot of training to give good result
Yes,
in
ma'am.
adenomyosis.
Yes, ma'am.
Now,
Definitely.
now, madam, last 10 minutes are there.
Yeah.
I want to talk about the new kid on the block and also the medical line of treatment. If the patient doesn't want fertility, we have done this surgery. How do you prevent the recurrence? The best of the best we have done for her.
Madam, start off.
Yes,
Me? Okay,
Don't be the
okay.
last person talking.
Have so many things. Oral, starting with oral contraceptive
contraception.
pills and progesterone, but current evidence is moving from that. But now we have natural estrogen, Clara also, and progesterone is also good, Dynogest, and now we have elagolix, which we are prescribing a lot. And GnRH is a very strong drug. It is very effective, but it has lot of side effects. It should be sparingly used. It should not be just you are giving for years together. So, and after Mirena, LNG IUD is another very good option in patients with contraception, especially when you operate and she is not wanting further fertility. Putting an LNG also a very good idea. And now GnRH antagonist, which has so many advantages over these progestrogens, they have horrible breast tenderness, mood swings, weight gain. So every drug has its place. It depends on cost, patient profile, affordability, and side effect profile.
Dr. Bhaskar, sir.
Yes, Bhaskar, we go ahead.
But I want to have the last word.
Okay. We used to use, I think the bottom line from what Madam said is that if you want to prevent recurrence, you have to put them on some form of medical treatment.
Yes.
What form of medical treatment that varies? That varies depending on, as Madam said, what the patient wants, what you prefer. I think from the time diagnostics have come in, we have moved on in a big way to diagnosis, but there are two major problems with diagnosis. One is the cost. After some time, the patient starts complaining about cost, and number two are the progesterone-related symptoms. Elagolix, again, you cannot, as of now, the data doesn't exist for more than 1 year. And if you are using the higher dose, which is 200 milligram twice daily, then there are abnormal lipids. But the 150, you should be able to keep it for longer. A very interesting paper has come out last year, where they compared post laparoscopy 5 years of Dynogest versus 3 to 6 months of GnRH followed by 5 years of oral contraceptive. And they showed that the recurrence risk is the same. So I think that is also another option. Give them GnRH analog for 3 to 6 months and then keep them on a oral contraceptive pill.
My take on all this depends on the age of the patient. So if she's a younger girl, what I would do is post-surgery or that Dynogest is my first drug of choice, OC pills and Dynogest. Again, I'm coming from a that's a hospital where I see a lot of DVTs. I would prefer Dynogest over oral contraceptive. I've seen amputation of the hands even with one tablet of OC pills. Because for all patients, we do not go ahead and do homocysteines and protein C, protein S. So these are the things which happen. So I prefer Dynogest for a younger girl who comes to us and who are married after surgery and do not want pregnancy. It is going to be Mirina. Married after surgery who want to go in for pregnancy. I would, till recently, I was giving the GnRH analog for 3 cycles followed by immediately pregnancy treatment. But now with elagolix, we are giving a lot of elagolix because of no flare-up thing, and the side effects profile is the same. So I'm going low dose, 150 OD only, going for 3 months, not BD. So we'll see how the results are going to be. But again, another segment of patient which I want all of you to remember, that is perimenopausal post-hysterectomy, where we see lot of endometriosis. We do not do oophorectomy, only cystectomy. These people also need that. So in that age group, I prefer to give aromatase inhibitors, that is letrozole for 9 months, which is fantastic thing, especially vault adenomyosis also will be prevented. So I take my call depending on the age of the patient. We can use whatever we want, like how comfortable we are, but we should know their side effect profile and counsel them accordingly. And definitely in Indians, osteoporosis is very high. So GnRH and elagolix are never more than three months. That's it. I don't give more than that.
For elagolix, there is very good data up to 48 months. Yes. And one thing I would like to say, elagolix has recently come in. We are using a lot, but I have gone through very deep into the literature of elagolix. So if there is severe dyspareunia, start with higher dose. And dyspareunia correction is very good with high dose 200 BD elagolix. Then put her on maintenance 150 OD. And there is long-term data with elagolix and hardly any bone loss.
But all this
has her periods. Many patients, they hate that they are not getting periods on Dynogast. With elagolix, amenorrhea rates are less. And this natural containing this Clara, which is natural estrogen, estradiol valerate containing OCP, again is a good option for very young girls who want contraception surely and they want their periods.
Yes, ma'am. Madam, what you said is absolutely true. But most of the studies which come for all these hormones are not from us. It is from Western world. And their lipid profiles are different. Our lipid profiles are different. You have
Ours are better.
No, madam. In a very obese patient, there also their triglycerides will be normal. What we need to understand is our progesterones definitely work through the lipid profiles the way they do. So the way our body responds are very different. Our osteoporosis levels are different. So definitely with elagolix and a long term, I think we need to think with a pinch of salt. Maybe 3 months.
Elagolix is not as harsh on the bones as Dynogast.
Agreed, madam. Even with add back, I think we should. I don't know. That is my say. My thing is we should be very careful with any GnRH.
We don't have long-term experience with elagolix. For 3 months only we are using, but we are quite happy with it.
Yes, ma'am. That I agree. I'm using it a lot. Dr. Bhaskar, any say on that?
No, absolutely. I don't think there's any concern with elagolix and bone loss. I think elagolix, the worry is with lipid profile. It is not really with the bone.
That is right. That is right. Yes, Dr. Niranjan.
Yes.
I hope you got most of your what you wanted from us.
Niranjan, you summarize and it is 8:30.
Yes.
Yes, madam. I just wanted to conclude the program. We have gone wonderfully through the dynamics of endometriosis. And I want to add before I conclude, there are many luminaries which are present today. And I can see Saumini ji, Dr. Varsha Baste, who is there. Great discussion going on by legends. Dr. Alka ji, Dr. Manjula, Dr. Bhaskar. Varsha Baste says, "You talk brutal truth, dear Dr. Mangeshikar sir." These are the remarks which are there by Dr. Varsha Baste. She is our sitting vice president. Thank you, madam, joining. Well, Saumini has a different opinion about Dynogest. She says that it doesn't work up that much as compared to what are the other drugs which are being discussed today. There are certain therapeutic options for surgically treated endometriomas. And that therapeutic options you all have said very nicely in one by one way. And the best option, which Dr. Alka Kriplani said, and Dr. Manjula Anagani, as per the age of the patient. So many, we have answered that question. And we have Dr. Sandesh Kade, who is most of the time abroad, sitting in Middle East, hopping around from Aurangabad and doing a great work on endometriosis and fibroid. His comment is, resection came into clinical picture when we started involving gastrosurgeons. Yes, we agree, and too much resection has gone ahead and we need to control that. So with this,
I must thank Sandesh Kade for his
telling
comment.
him, openly, agreeing to that.
Yes. So with this, I have summarized the best part and I hand over the mic to Dr. Komal to conclude and say.
No. Before you hand over to Komal, I want to say one thing. Dr. Niranjan and Komal, you have done a wonderful job today. And nobody can say you know. So whomsoever you give a call, has to say I will be there. And Jubin, Dr. Nozar's son, huh? Such a lovely boy, and he is giving calls to everybody. But 3 cheers to Niranjan and Komal Chauhan.
Thank you so
I
much,
think
madam.
I think
Cheers from
Niranjan,
you means a very lot.
I think we've
Komal,
seen
let
from
Bhaskar
COVID.
say something.
I think we've seen from COVID times, Niranjan as a moderator speaks the least and gets the best out of people, and he makes other people fight. And Alka madam, please don't tell Zubin a boy. He's no longer a boy. He's a man now.
Oh, he is a boy, at least I can see. Maybe you are younger.
But he looks exactly like
handsome boy, handsome boy.
Yeah.
Yes.
Thank you, ma'am.
So thank you so much, all the luminaries and the icons who have joined today. Dr. Alka Kriplani madam, Dr. Mangeshikar sir, Dr. Bhaskar Pal, Dr. Manjula Anaghani, and it was such a lovely, energizing discussion, to hear that small words of wisdom and tips which each one of you have given in this span. I think getting the filtered information from each one of you was the gist of this entire podcast conversation which we had, and the best practices which we are going to follow. Every time we are going to open up a surgery, we are going to remember your golden words. So that is what the message which every viewer is going to take. And I thank you all for joining today. And we will come up with such good discussions. And thank you for blessing us on the first occasion. And thank you all the viewers who have joined today. Thank you so much. Thank you, Zubin and the Sahiti and the Shield Connect team for the excellent session. Thank you. Thank you so much.
Thank you, Niranjan, and
Thank
we
you
wish
for
you all the best.
organizing.
Yes.
Thank you,
wish you
and
all the best.
Wish you all the best.
Thank you. Thank you so much.
Bye-bye.
Bye. See you.
Bye. Bye, Zubin.
Bye, sir.
Bye.